Okay, welcome everybody to the Colloquium. Very happy today to have Dr. Bradley MacIntosh, who's a professor of medical biophysics, currently located at Sunnybrook Hospital at the University of Toronto. So we actually go back all the way to my undergrad and Brad's master's degree when we were both at the University of Western Ontario. We have always had a little bit of a yin and yang relationship in that Brad has always used MRI to study the blood flow of the brain, whereas I've always used MRI to study the structure of the brain. So I think Brad is going to be a very interesting speaker today for three reasons. The first one is that psychology is very interested in using fMRI as a readout for psychological experiments, and that's all blood flow in the brain, which we never hear about because I don't do blood flow stuff. So this is interesting to people with an interest in fMRI. Secondly, it's interesting because over the years, as Brad's moved from his master's degree at Western to his PhD at the University of Toronto, and then to a postdoc with Peter Jezzard at Oxford University, and then back to Sunnybrook Hospital in Toronto, he's been moving sort of towards looking at how blood flow is related to different clinical diseases, and especially in the context of aging. So he's also got a lot of interesting things to say about stroke and small vessel disease, which is becoming interesting in terms of dementia. So that's exciting as well. And then the third exciting thing is for the students from my undergraduate neuroimaging class I invited, Brad is also getting into AI methods and deep learning to analyze images. And I'm sure we'll do a much better job explaining how that all works today for us than I would. So as I said, Brad's current laboratory is at Sunnybrook Research Institute in Toronto, but then he also has this affiliation with the Oslo University Hospital in Norway, and again, helping them out with some deep learning stuff. So I'm going to turn it over to Brad, and let's give him a welcome and hear about the cerebral blood flow side of MRI.
Great. Is the mic working okay?
Yeah.
Yeah, great. So it's a great pleasure to be here. You saw me limping in, so I'm gonna be strong in this presentation. Don't let the crutches cast any doubt. And Alex asked me not to name Alex in thanking him, but I want to thank Alex and the organizers because and Jonathan, who I've now just met, and the others that were involved. I mean, the Colloquium is only ever as good as you make it. So I'm up here, but it's the audience and the organizers that do a great job. And so my thanks also goes to Professor Noseworthy and Professor Bach, or Nick, for creating a great environment here for teaching and learning. So you can see the picture. I couldn't resist the incredible picture of the vasculature of the human brain here. And this is a 7 Tesla scan of a human healthy volunteer. And the anatomy of the mostly arteries has been something I've been fascinated with for a long time. And I won't read the title because actually the content's going to be changing a little bit. There's going to be a bit more on stroke and a little bit less on Alzheimer's disease. But we'll see as we go. As a narrative style for the outline, I'll try to convince you that the research that has been conducted with MRI demonstrates it's a highly versatile technique to study the human brain. There will be functional imaging approaches as well as anatomical to showcase that. And my role has been over the years is very clinically oriented, so clinical translation. If you think you have a really good imaging measurement or you have a great psychological assay, the question is it good enough for a clinical application? So we will embark on that, and I'm going to make a use case for, spoiler alert, Nick already said, cerebral blood flow in the context of a clinical trial that's ongoing to treat depression. And there's a lot of interest in artificial intelligence in radiology, so I'm going to spend some time on that. And then I'm going to tell you about specific examples where we have used AI deep learning as it relates primarily to stroke. So I hope that you see this as a coherent storyline, but the truth is that there will be certain topics that are more interesting to you than others, and that's fine. I was trying to give a smattering of topics here. I have a couple disclosures that I'll just state here and provide a more tangible roadmap. So we'll start with some MRI, and vascular imaging will be the thing that we can start with. So this was also just a bit of a setup. So the arterial spin labeling has largely been on the backs of research done at Sunnybrook, where our approaches are to use arterial spin labeling in very different types of patient populations, small vessel disease, type 2 diabetes. And the main idea is that because these are all chronic conditions that increase the risk for both stroke and Alzheimer's disease. And now we have this new 7 Tesla. Anybody hear about this in the news? Yeah, okay, of course, Mike did. So this is a very expensive piece of equipment. It's extremely expensive when you factor in the construction costs. So it is meant to be a pan-Toronto resource, and I think that Hamilton ought to be included in that as well. So there's a little a tip for 7T. The other research you'll see is through collaborations and affiliations at the Center for Addiction and Mental Health. There's the Center for Youth Bipolar Disorder, so not adults and not stroke, but vascular imaging is a key thing that binds us. And then the deep learning stuff was actually stuff, I did a sabbatical in Oslo, and that's where the deep learning really played a prominent role. So this is a pretty easy opener. How many of you know which one is the MRI scanner? Is it the left or the right? How many people vote for the scanner on the left is a MRI? Anyone MRI on the right? Okay, yeah. Sometimes people will find that difficult because they look they look very similar. MRI's costs are actually coming down. They're trying to make MRI scanners less costly, and the CT scanners are getting better and better. So it's just a neat thing to start things off, and CT is going to come in for the win at the end of this presentation. I'll tell you why. Maybe not the win, share the prize. So with MRI, arterial spin labeling is just one of the many examples. It's a versatile modality allowing us to do things like tag the blood magnetically. And that's what's represented here is you have an out-of-volume preparation in your ASL acquisition. You tag water that's in blood moving into your imaging plane shown in yellow. We all know, of course, the blood moves this way in arteries from the aorta into the carotids and things. The idea is you label as it's in larger vessels, and you have a time delay when you pick up that tracer, that freely diffusible water tracer. So the scenario with arterial spin labeling is that there's different scenarios. You can, there's the acquisition and the water molecules, which is the spins in water, get tagged magnetically, and then it influences that signal by causing more variation in the T1 values, causing that signal to drop down. So you have a control image and a tag image. The subtraction of the two gives you perfusion-weighted contrast. This is an example of an arterial spin labeling perfusion map. It's getting better and better, and it used to be, and I'm going to do a kind of narrative on that, it used to be quite a clumsy technique, but what I'm most excited about is now these images, the image quality is getting really good, and I'll tell you a little bit about how it's unfolded. So 30 years, some of you are, most of you are under 30 perhaps in the audience, and the very first papers for ASL appeared in the 90s, around the same time as this other technique, which is the fMRI technique called BOLD. That technique was also created around that time. And although BOLD gets a lot of attention, and I know a lot about that topic, it's interesting to see that ASL, as a non-invasive perfusion imaging technique that is quantitative, has been gaining momentum. On the left-hand side is this classic kinetic theory for how when you have these tracer of freely diffusible water signal in arteries, it will accumulate into your tissue of interest, governed by the flow rate here. So F is flow, so you increase the flow, then that sort of will dictate how much this tracer signal accumulates, and then how much it decays is based on this tracer does not last very long. It's a freely diffusible tracer of arterial blood water, and that signal dies away according to the T1 of the arterial blood. So you got about 3 seconds to make your measurement. The neat thing about imaging with MR is that you can just repeat this procedure. So in a lot of great stuff happening in the 2000s. I'll just skip ahead that in the mid-2010s is when this consensus article came out, which I had the pleasure of being a co-author on. And we said, okay, what are we going to recommend for this sequence? So we came up with the recommendations. It was around that time that there was a patent that was submitted. One of the 3 vendors, I won't say who, you can check out, Google it later. They made a patent on quantitative perfusion. So that was both a help and a hindrance, making it a bit more awkward for the other 2 vendors to have what they would consider a quantitative map coming right off the scanner. But that's a bit of scuttlebutt. Now, in just last year, we produced the 2nd recommendations paper. And what we're advising is that to take advantage of this inflow accumulation signal and then decay of this signal. So you can actually, it's like taking a picture and watching this wave of blood flow go into the brain and then having that tracer disappear. So it's very much like a pharmacokinetic kind of experiment. And I think that is where we are now poised for the next leg up on how ASL can deliver perfusion imaging for clinical applications. I don't have time to go into the many examples where the ASL signal has delivered and given new insight from neuroscience and psychology, but many of it is clinical applications. So if I kind of just walk my way through from each of these little bullet points, we have an appreciation for this signal. It's actually, we call it like ASL perfusion contrast. So it's not, it has its quirks. It's not the same thing as a O15 PET. It's not the same thing as a CT perfusion, but it's quite robust, and we have to just be mindful that the signal is capturing a delivery of this tracer. It's vanishing within seconds, so this transit time issue, something that I spent a lot of time on, and we can harness that information. The other interesting thing is that it's like a resource, that perfusion is based on the metabolism of the brain tissue. So as there's higher metabolic needs, there is a compensatory increase in perfusion. So by measuring perfusion, you're measuring actual brain metabolism. So we have more of an appreciation of that. Now, that hat that I wear, which is with the Center for Youth Bipolar Disorder, we've had a lot of discoveries that relate to mood alterations and severe mental illness. What we've noticed is that certain brain regions, the perfusion signal goes up and down depending on the mood state. And that has been not only supremely interesting, but also helping to destigmatize mental health disorders and to say that there's biological constructs behind your mood. I'm going to tell you about Embrace, a clinical trial, and also just to note that there's roughly 5,000 ASL papers, so a lot of which is happening in a technological-driven domain. So there's a lot of reading to do if you want to dig into it. But I wanted to shift gears, and the idea that we're able to measure metabolism, the use it or lose it, areas that wire together, fire together, all of these constructs that you know from your psychology learnings. We wanted to pursue that and revisit something that's a project that was led by Guochang Zhang, one of the PhD students that I supervise. This is just a recent publication, so I'm excited to tell you about it. So everyone knows about the thalamus here, right? Of course, a lot of head shaking. So it's a central relay station. It's 15 milliliters in size, and there's at least 15 nuclei. There may be more. and that's what this picture is down here, is to try to convey at a organizational level. It is Grand Central Station, or pick your other train station as an analogy. So does it participate in cognition? We wanted to investigate that, and so we wanted to compare and contrast information from anatomical imaging, looking at the hippocampus here in pink and the thalamus highlighted in blue. And Guo Chang made this slide. So the projections from the thalamus to the hippocampus, that is represented here by the green projections from that anterior nuclei. It's going to other brain regions, so you can get a sense for what those connections are doing. Then there's also different circuits, now seeing the emotional circuits with that amygdala playing a role. Sensory regions, as well as motor participation in motor actions and things related to actions. So clearly, the thalamus is important. What we wanted to do is investigate the thalamus in relation to cognition, which the size of the thalamus could participate in supporting cognitive performance. And we also wanted to look at the relationship between the thalamus and the hippocampus over time. So to do that, we made use of the UK Biobank. Have people have heard about the UK Biobank? Yeah. Yeah, one of the most impressive feats that is ongoing in the United Kingdom. It's not without its challenges and blind spots, but the fact that there's over 500,000 people that were in the study, many tens of thousands that participated in the MRI scan. What we wanted to know is when, in the context of neurodegeneration, the thalamus is changing, other brain regions are also participating in neurodegeneration and aging. So can we focus on the size of the thalamus and look at the relationship between thalamus volume and cognition? So we thought this is more of an aging story, so the population, it was naturally skewed in the UK Biobank, but we chose people over the age of 60. We also chose people that had repeat MRI scans. So we want to look at their anatomy at follow-up, which is 2.5 years later. The sample is, fairly educated, pretty balanced for sex, very, very heavily skewed towards white ethnicity. So that definitely is a limitation. But in terms of the MRI analysis, it was pretty straightforward. We have the T1 weighted image, which I'm sure you have heard about, and then 4 cognition tests. Actually, more like 3, but you have the trail making A and B. People know that. That's the good old-fashioned trail making test. There's a digit symbol test and a numeric memory. So first question is there a relationship between performance on those 4 tests and the baseline thalamus volume? And you can see, yeah, I guess so. When you have such a huge sample, you see it, right? In the case of the trail making A, it's not a significant trend. So there is a relationship. But what is the unique effect of the thalamus? The thalamus is, if you think about cognition, it's a very complex set of orchestration of thoughts and stimuli to lead to an action. So of course the thalamus ought to be involved. Now what we did is we made a composite of those different cognitive tests. So higher composite score is better performance. And here is where it started to become a little bit more clear, because we're able to account for so many covariates with a large sample. So these are the list of factors that were considered. So we're really accounting for the size of other brain regions, as represented by this list here, total white matter and other brain regions. But the thalamus still managed to squeak out in the standardized beta significant p-value. So, all right, that's interesting. The size of the thalamus matters. Now, how does it relate to the hippocampus, which is really more of the holy grail of cognition and memory? So just to remind you, we have the baseline and MRI scans separated by 2.3 years. Is 2.5 years enough to observe changes in the brain among people in in their later decades of life? Well, this paper from over 10 years ago, they argue yes. So they look at the blue here corresponds to annual change in that brain volume. So what are we seeing? Well, we're seeing almost a 1% volume reduction in the hippocampus, and it's the temporal lobe here, the mesotemporal lobe. So we know we want to study the temporal lobe and specifically the hippocampus. So what Guo Chang did, which is a really interesting thing, is to link a series of linear regression models in a formalized statistical test called bivariate latent class statistics. Anybody heard of that? To be honest, I hadn't heard about it either a couple of years ago. But it was interesting because, of course, we know that the change of one brain region is going to be related to the change in the other. So while this is represented, the baseline hippocampal volume and the baseline thalamus, yes, they are pretty tightly related to each other. So that means that along the top, you have the thalamic volumes. Along the bottom, you have your hippocampal volumes. And then the question is, those circles there, is that what's the delta for the thalamus and what's the delta for the hippocampus? After you account for all these sources of covariation, you can say this connection here, beta t, that would be the unique amount of variance where the baseline thalamus can explain that change of the thalamus. And then vice versa, or similarly, this gamma term here is how much the change in the hippocampus can be explained by the baseline thalamus. So it's neat. When you have enough data, you can do these kind of structural equation models. As I suggested, yes, there's a high degree of correlation early on, for the baseline. And these are the parameters that are estimated from the BLCS model. And what we found is that the delta hippocampus can indeed be explained by this term here, which was after accounting for the baseline hippocampal and the other parameters. So it was quite a nice demonstration that the way I would think about it is that the larger your thalamus, I think I'm going to say that here, the larger your thalamus in your initial scan is protective against hippocampal atrophy. Kind of neat. We also noticed some sex differences, that there seemed to be a stronger signal in sometimes men and sometimes women. So it's a cool paper. We satisfied these aims, helping to reinforce thalamus is easy to segment. It's on every, pull it out every T1. So it's kind of interesting to consider it alongside your conventional brain regions that contribute to cognition. And this is quite kind of novel, thinking about which brain region is a leading indicator of aging and neurodegeneration and which one is not. So you can read more about it in this publication. So that was a bit of a digression to satisfy our curiosity about anatomy. So now we're going to switch back to perfusion imaging with ASL. And we're going to move to the forest. Many of you will have heard about the interest and excitement in the field of psychiatry as it relates to the use of synthetic psilocybin. It's kind of an interesting story. Maybe we talk about it afterwards, where when I was first approached, do you want to do some research on psilocybin? No, I don't actually. And then it was like a couple more times. No, I'm telling you, man, this is really interesting. There's a lot of imaging. There's a lot of things in here. And so I started to come around and I thought, okay, this could be really interesting. It was not for the faint of heart, because there's Health Canada regulated trial, trying to get both seed funding and recently secured funding from Physician Services Incorporated. And there's no need to say much about major depressive disorder as a leading cause of disability worldwide. The uses of SSRIs, of course, have been around for decades. It's a messy field. They are not perfect. There's rotating through different formulations. And in 2021, there was this paper published in the New England Journal of Medicine. So, we want to take note of something like that. A reasonably small trial, but they compared one of the conventional SSRIs, escitalopram, against psilocybin in a proof of principle study. And what they found is that two macro doses of synthetic psilocybin, so 25 milligrams each, over a couple week span, was associated with the behavioral and symptom relief that was comparable to taking the SSRI daily. So a lot of people started putting up nice pictures and saying, oh, we can do psilocybin research. And so we can do psilocybin research. But what is our unique angle here? So there's a lot of trials, and Canada has actually been quite ambitious in pursuing this on several fronts, and the data continues to accumulate. And I wouldn't say that I'm an expert on the neurobiology of the serotonin and the 5-HT receptors, and there's people that know this stuff very, very, very well. But what I can bring to the table is thinking about the brain circuits that could be participating when somebody is taking psilocybin. And so our trial is, it has to be done with a registered psychotherapist on hand. A clinician has to assist in this process. The general concepts here as part of this therapy, which is like 6 hours, being watched, is acceptance, connection, and embodiment. So you can read some of the terminology that is part of the psychotherapy angle. But what we're really interested in is when somebody takes psilocybin compared to when they take a placebo, are we able to identify brain regions and circuits that are showing functional alterations within hours? So the study design, there's, and I didn't mention, on the right-hand side, you have Josh Poulin, who was a research assistant. Now he's a master's student, and he's leading this. He wrote the trial manuscript, he's the first author. And then the psychiatrist with this bold vision is Sean Nestor, a colleague at Sunnybrook. So what are the acute effects of psilocybin on the brain? If we measure this perfusion signals in people with treatment-resistant depression. So they get a baseline MRI scan. A couple weeks later, they do treatment 1. A couple weeks later, they do treatment 2. So this is a randomized clinical trial. It is a crossover design. Do people know what a crossover design is? The crossover design is that that is the placebo. So on the first treatment, half of the patients with depression, they will receive the placebo. And then on treatment 2, both arms receive the active ingredient, 25 milligrams, synthetic psilocybin. So we're not going out into the forest and looking for mushrooms and harvesting. It is a properly sanctioned medication, all done with the best governance and paying a lot of money for it too, by the way. It's expensive to source this readily available substance in nature. Now, the interesting thing is that we know, everyone that does treatment 2, we know that they will have received the active ingredient. So we've run this a couple of times now. It's going well. And the perfusion images at baseline look beautiful. So I'm very excited about that. You can see what we have here is that montage of those ASL scans. Now, it's hard to read, sorry, in the back. The post-label delay number, this is a number that's incrementing from 1 second out to 2.5 seconds. So this is just a demonstration. This is one participant. So if I saw these images 20 years ago, I would say, wow, this ASL, it really has a chance. Look, you can see it in the raw data. So I was very patient in waiting. Now we can clearly see that this is the composite cerebral blood flow map in absolute units, where we're poised to ask the question, which brain regions are going to show evidence of target engagement? So I'm excited about the EMBRACE trial, which I didn't define, stands for Engaging Mood Circuits with Psilocybin. So that is one example of a clinical trial. And for me, it's always been a great experience to work closely with clinicians and finally hear them say, we're ready to include that measurement that you physics folks have been saying is good. Now we want to put it in a clinical trial. So the ASL it's been gratifying. We've done it in a few different clinical trials. But I wanted to shift gears because the talk did say deep learning. There's been no deep learning yet, and we're half an hour into the talk. So here comes some stuff on deep learning and decision support. So this is a slide that I generated, and I accessed data from the FDA's website. And the pie chart here represents the many, many hundreds, in fact, thousands of cases where the Food and Drug Administration has approved a medical device, and that medical device supposedly has an AI angle to it. So the lion's share of FDA approvals, 956 approvals, is radiology. So it's a good thing that 3-4 years ago I started to do more AI in radiology, because it was very clear that this trend in radiology is a strong use case for AI to help in various hospital settings. So what could AI do in radiology? Across the top of this list here are things that we will talk about a little bit, and detection and triaging, segmentation and quantification, image synthesis, outcome prediction. So I actually started doing research with deep learning as I was doing image synthesis. That was like a way to get into it. It actually didn't work out very well early on until we found ways to really make it work. And I would say the biggest part of the use of deep learning tools in imaging is the detection business. Now, coming down the pike, of course, is really exciting things where it's image and text and very complicated models. So I think it's quite an interesting time to be incorporating deep learning into medical imaging. So this slide is one where it's really it shouldn't be a surprise how much AI has been a part of basic science for decades now. I like this slide because actually it was a colleague that helped make this slide, but it was last year when Hinton and Hopfield won the Nobel Prize. They were thinking, we're physicists? Oh, cool. So computer science scientists win the Nobel Prize for physics, and it's on the back of lots of incredible computer science work. But I would argue where some of the research has had the biggest application for imaging is this bend here in 2015, 2016 with the use of ResNet, UNet, DenseNet. Okay, so my primer, I'm going to explain a little bit about one UNet architecture that we've spent a lot of time on. But I wanted to say, if you're interested, and you may have tuned out, and now you're back in with us, DenseNet, NNUNet, and XGBoost, those would be great places. So if you're going to write something down, that's the thing to write. Now, the funny story, the NNUNet, it was actually the most cited, it's one of the most cited papers in the last 100 years. Truly. And it was the abstract from a conference. So the researchers that came up with the NNUNet, we better publish something because this is taking off, right? So just in the last couple of months, there was news about the role of the UNet as having such a huge impact on science. So there's a lot of buzz, and this is becoming very standardized. So the task that we have thought about in the research activities has been, okay, detection, not really triaging, actually. We're not going to triage anybody with the tools we're developing, but we're going to detect, we're going to segment, allowing us to quantify, and maybe if we're lucky, we will do some research that will allow us to make a prediction about an outcome. So we're going to now shift a little bit towards the stroke in the back half of the presentation. So while all this AI stuff is happening, there's been incredible breakthroughs in the field of stroke. In 2003, the Nobel Prize for Physiology and Medicine, it went to inventors of the MRI technique. And a lot of people say, we could hear from the people in the audience that know more about this, is that the MRI diffusion weighted image was that killer application that really said, we have never been able to do this before. And that's the one thing where MRI, that's worthy of a Nobel Prize. So that was, decades ago. And then going around the bend here, this is when companies like Rapid AI and iDoc, Cure, these are all companies that have created software tools specifically to address stroke and also use artificial intelligence. And then in 2019, something interesting happened is that Radiology, which is the top journal, you can imagine Radiology is the top journal for medical imaging. They created a daughter journal called Radiology AI, and it's been a lot of publications that, frankly, you can't keep up with it. Of those FDA approvals that I mentioned, and a couple slides ago, 37 of which are stroke applications. So we're shifting gears. And I think I'm going to actually need some audience participation soon. Because I'm an MRI person, and like getting into CT, I feel, I shouldn't have done it. Maybe Mike is going to be mad at me. But there's no denying that CT is the clinically dominant modality. So if you're thinking about clinical translation, you really want to listen to what doctors say and clinicians say in general, and they love CT. And the reason for that is that CT is the first scan that a patient would get if they have a suspected head injury like a stroke. So public service announcement, you know about the signs of stroke with this acronym FAST for face droopiness, arm weakness, speech difficulties. It's time to call 911. When someone has a stroke, if they get to a hospital in time, the door to needle is such a key measurement because we have such good therapies for ischemic stroke. We actually have two amazing therapies, and not enough people still get those therapies. But that's where this non-contrast CT is the first thing that will tend to happen. And that's what's shown on this picture here, followed by other scans that are all getting more interesting and more detailed. But it's that non-contrast CT that got us interested. Because if the flip side to an ischemic stroke is a hemorrhagic stroke. And you cannot give the clot-busting drugs to someone that is having a hemorrhagic stroke. So one in six acute strokes are hemorrhagic, and then roughly 5 out of 6 are ischemic strokes. There's mimics that slide in there as well, but we won't go into that. So imagine a hemorrhage that is the spontaneous rupture of blood vessels in your brain that can reach the size of a ping pong ball, which is 30 milliliters. Do you need an MRI scan? No, actually, to diagnose a hemorrhagic stroke, which I'll call a brain bleed, you really only need that CT scan. Now, if somebody has a head injury, that would be not a stroke, but a traumatic brain injury, a mild concussion, maybe loss of consciousness, the CT scan is also used. So in that case of what we consider a mild head injury, fortunately, a brain bleed will occur in a very small proportion of people, 5%. But to a radiologist, what's the difference? They're all brains, and they all come in acutely, whether it's a big hemorrhagic stroke or there's nothing there due to this person with a head injury. It's the CT scan that's at play. Now, this could be a devastating hemorrhage, and it becomes complicated because of the fact that it may expand and it may start to accumulate into the ventricles. So now we have an injury and we have a secondary injury, and intraventricular hemorrhage is an escalating problem because as you know, the brain has nowhere to go. The mass effect can produce problems to rising intracranial pressure, and that's when things can get very bad. There's also trauma type events like subdural hematomas, which are very common. In fact, subdural hematoma is if it isn't already, it will be the #1 reason for a person to receive neurosurgery. So over the years, the focus on brain bleeds with the non-contrast CTs. This paper from 2023, they actually show that from various 26 different papers, the receiver operator characteristics, if you've heard of that before, what you want to do is maximize the sensitivity without paying a penalty for false discovery rate, or false positive rate, I should say. So you want to be up and to the left. And that's where many of these papers claim to be. And so this is where the types of indication for brain bleeds, both stroke and trauma. And so now, Alex, patient #1, you're training to be a radiologist, neuroradiologist. So can you tell me, based on the knowledge and very limited information that I told you, patient #1, they have a brain bleed. Can you tell me, is it in slice 1, 2, 3, or 4? And why, if you feel like answering that?
Maybe slice 3, because I see this liquid spot.
Mm-hmm. Okay, great. Jonathan, you're up next. And don't worry, I won't pick on any faculty. Do you want to say patient #2?
Yeah.
There is a bleed. Do you want to say which slice you think the bleed is in? Or maybe more than one slice?
I'm going to follow Alex's lead and say slice 3.
Yeah.
I see that there.
Yeah, great. Oh gosh, someone in the back. I could pick on Pedram because he's a colleague of mine, but I'm not going to. Anyone want to try patient #3? Come on. Okay. Okay.
Could it be multiple? Is that also?
It's definitely an option, yeah.
Maybe 2 as well.
2 as well.
These are just guesses.
You got it. Okay, awesome. You look familiar, actually. I'm going to pick on you.
Let's say slice 2 and 3.
You got it. And then maybe your colleague to your left? This one is a little harder. What do you think? Patient #5. Slice 2. Okay, so you guys are way too smart. I'm just going to pack up and leave. But what we all just did is that we all just trained our collective neural network, right? So that's how easy it can be for a neural network. So that's why I got excited about using a deep learning model. Because the reality is that this is a very complicated case. And where I want the technology to be able to work for those cases. But how about this patient that was scanned actually over 10 times over 65 days? Their first scan that we had access to, I deliberately blurred some of the dates. But you can see they have, this was a traumatic bleed. And you can see it's in the top. There's a trauma. Then, because they are neurologically declining, you can see that top, they had to introduce a drain. That was not enough. They had to perform a craniotomy. Now we have a bone flap. After the bone, there's another bone flap. Actually, the bone flap, the bone flap has been reattached. And they're monitoring the patient, and 65 days later from that initial scan. So what I would say is the tremendous opportunity for AI applications is not just doing the detection one and done. Is that we need systems in place to integrate 65 days worth of data. And the only way to do it, I believe, is with AI, because no human can comb through all this. So that was a real motivator. And in 2022, we started working on Viola. Yes, I came up with the acronym, and yes, I love the Viola. It's a beautiful instrument. So what we wanted to do is, Viola stands for, very geeky now, voxels intersecting along orthogonal levels of attention in a UNet framework. So what does that mean? Don't worry about it. It's that UNet that I told you about as being such an important discovery for image analysis. And the twist on it is the brilliant work by my colleague Brian Liu, is that if you're just looking for ping pong balls in an image, you really don't need to take in the different feature space information that you would see as you do the classic descending and ascending arms of the UNet. However, not all bleeds are the same. And so this attention module in the upsampling branches allows us to segment not only the ping pong balls, but also the wet noodle that may be blood in multiple locations. And so we actually joined a data challenge. We won the data challenge. It was really amazing experience. We were robbed of first place because we had an artifact in our data, but we did win the validation phase. And we were very excited about this idea. We didn't realize how popular the NN unit was going to become. We knew about it, and we basically implemented a variation on the NN unit. But now, by using the NN unit and having some different tricks at play, this tool allows us to segment the different locations where there's a bleed. But what we really also want to do is decide what type of bleed it is, because if it's a parenchymal bleed, then that is a slightly different treatment course compared to intraventricular, subdural. So we want to color code it as well, and that is work that's ongoing. The performance over the years has been up and to the right for sensitivity, specificity, and the area under the curve. So you can see that we've actually trained 4 versions of Viola, and it's getting better and better as we get access to more data and by working very closely with colleagues. So I think I have about 10 minutes left-ish. Is that right? Yeah. So now I want to tell you that idea of doing a little bit, creative ideas with AI. So we can segment the bad thing. But what we realize is that whenever there's a bad thing, there's always something else in the brain that may be related. So almost like the way we're thinking about the thalamus and the hippocampus. Now what we're going to do is we're going to think about the brain bleed, and we're going to be thinking about the lateral ventricles. So that is what we call the VBAI. What we did is we did a dual segmentation. So it's a neural network on a relatively modest amount of data, and the model is being trained to segment the location that's the bleed as well as the lateral ventricles. So these pictures, they might be hard to see, but the blue is the ventricle, and then in this case the yellow is the bleed. And so everyone has a ventricle, right? There's actually 6 chambers for ventricles. But there's the lateral ventricles, there's the 3rd and 4th ventricles. Pedro knows a lot about it because he worked on it for the summer in my lab. But this is actually work by a master's student who graduated. And what we found is that from among the different architectures that we would consider, it was again, that NN unit, which is a 3-dimensional NN unit, that actually tended to have a slight edge in performance. So then we said, we're ready to roll. Now what happens if we run VBAI? So it's segmenting both the bleed and the lateral ventricles. What happens if we just unleash it? So this is actually an open source data set. What's rotating through here is different cases. You can see the number is updating, and that is a different open data source. So blue, 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 blue. Everyone's got a ventricle. And so we're able to segment the ventricles. Some are big and some are smaller. Now I'm going to just fast forward a little bit. They're sorted because now the latter cases, you're going to start to see red voxels as well. So what we want to know is how big is the bleed and what is happening to the ventricles. So this is really great. It allows us to do things that we've never been able to do before, like this relative stuff, and I'm going to get into some examples on that in a moment. So here's an example where we had TBI patients. So now it's not stroke, but it is bleeds due to a traumatic brain injury. 91 cases, people, they all had a baseline scan, and it was felt that clinically they needed a follow-up, so 24 hours later. So on the left-hand side is the bleed volumes. On the right-hand side is that same person, their corresponding ventricle size. So good news, what you see here is that for most of these TBI patients, the bleed volume is basically 0 or very close to 0. Well, even though there's a lot of biological diversity or a diversity in the ventricle size. But we have these bookends of the data set, which is here are the people whose bleed volume was very high but dropped very dramatically. And here are the people whose bleed volumes was low but increased dramatically. So now we have this relational information that if the bleed volume goes up, the ventricle volume may go down, it's just so simple. And I love the fact that we made this observation. And where we think that there's a good application for this is in patients that develop intraventricular hemorrhage. So we looked into it, and it's just an example that sometimes when you do your PubMed search, you got to go way back. In 1982, there was a Greb score named after Greb and colleagues. They actually came up with a scoring system. I was so excited. There's an actual score for your intraventricular hemorrhage? So I asked all my radiology colleagues, do you guys do the Greb score? No, what's that? So it's an example where there is a clinical pipeline, there's a possible clinical translation, but there's just no way for people to do Greb scores on all the patients. So we will let VBAI do it for them and serve it up to provide that decision support. And here's 2 cases of a patient. Their initial bleed volume is 0, and then 11 days later, something has happened. It's now 46 ml. The ventricle volume was 8.3, and then it's decreased. So that concept is there. One goes up, the other one might go down. That's an indication. And it's a similar story with participant 2. So basically, reaching the time, time is up here. And the ongoing research with respect to the AI applications is that we really want to focus on the hard cases. There's a need to get it right for every patient, even when they have a bone flap that has been removed, even when the bleed is very complicated, even when the bleed is very complicated, the bleed may have been there for weeks and months, and the patient may not even know about it, which is the case with subdural hematomas, where the blood basically takes on a life of its own in the space between the skull and the brain. And where we also think that we can take this technology is by helping come up with new research ideas and possibly clinical translation, where if there is a bleed that is severe enough, then what has to happen is there is a bedside procedure called external ventricular drain, where they do a burr hole and they pass a catheter. They start on the right, they go up and over, and they drill down until they get to the ventricle. It's like corking a coconut. Sadly, that's the best description. But they don't always get it right, and they have to do it at 4 in the morning, and it's usually done by neurosurgery residents. So we think that there is a way to help navigate this if we can segment the anatomy in question. So that's a new project idea. So wrapping up, I started by telling you about the amazing versatility of MRI. We made many discoveries as it relates to arterial spin labeling, tucking in some work on connectivity analysis as well from anatomical data. And then I hope I've demonstrated how AI can be used for decision support, doing more than just segmenting, but thinking about how that information can go downstream. And as I allude to here, AI tools that impact the lines of communication, specifically from the radiologist to the next person that could be in the circle of care. And so with that, I want to thank the many people and the research participants that were part of this endeavor, and acknowledge people, including Pedram, who did a summer research project in the lab, and sources of funding, and many collaborators.
Okay, so thanks, Brad, for shaking up our coconuts. And if anybody has any questions, boy, we got a lot to cover. Psilocybin, CT, MRI. So yeah, and I'll try to run around with the microphone.
That's okay. So I was just wondering if the end goal is a clinical application for this this AI model for imaging or segmenting brain bleeds.
Yeah.
Then why would you want to get rid of the landmarkers, for example, of like me thinking of me as a neurosurgeon, I'd want to know which area of the brain specifically the bleed is in. So why would you want to get rid of the landmarkers?
Right. So that's a great question, and I think maybe it allows me to clarify. So when they do the external ventricular drain, my understanding is that they look at a picture of the person and they will walk over and plan accordingly, what they call Kocher's point, which is 10 centimeters up, 3 over. But people have different anatomy, so that means that they have to use some additional fiducial markers to help them. And what we're saying is that if you know exactly where the anterior horn of the right lateral ventricle is, then you know how you can place your catheter. So we're not trying to remove information, we're trying to reduce the degrees of freedom in that very difficult process. So hope I addressed that. Yeah, thanks for asking that. Yeah, looks like in the back.
Yeah, so I don't actually know anything about psilocybin, but I found this study to identify circuits that are essentially activated by psilocybin interesting.
Yeah.
I believe that psilocybin activates nitric oxide synthase.
Okay.
So if that's true, how do you distinguish between indirect activation or indirect effects on blood flow through activation of neural circuits versus direct effects through nitric oxide?
Wow, gosh, I'm glad you weren't the reviewer on the grant. But it's a great question.
And as I say, it's not my field, but I feel like I've come across a number of instances where this has been mentioned.
Yeah, absolutely. So I would say psilocybin is really going to be like a sledgehammer effect on the brain. So when we say target engagement, we have some brain regions in mind. But to think that other factors may influence our measurements is absolutely up for discussion. What I would say is I don't know too much about nitrous oxide in that context, but nitrous oxide does have preferential nitric acid. Oh, okay. Okay, so then I don't think I can really. I thought my understanding is that the distribution of receptors is not uniform across the brain. But I guess what we're trying to think about is if it's associated with behavioral improvements and symptom relief, then we know which circuits in the brain are the ones to be driving that. So that's why we're thinking more about anterior cingulate, like you're guessing. So yeah, that's a perfectly valid point. We won't be at the level to really have a detailed understanding of which the mechanisms of action, but it will be about the locations that we think are important to study. Yeah.
Just to follow up on the question.
Yeah.
Are people being scanned while they're dosing? Like, are they tripping at that time?
Yeah. Yeah.
So it's a resting state scan. How do you account for that variability in someone is perceptually while they're sitting in the scanner.
Absolutely, yeah. So that, I mean, there's a lot of great research, and I'm participating in this, but Sean Nestor is the PI, so I kind of need to defer some of the questions to his insight. But our decision on that was that we need to know is that there's, and I can tell you, the people that have received the therapeutic dose, it's pretty obvious. I haven't seen it with my own eyes, but people say, oh yeah, they got the active. So we know that it's happening within hours. The peak is thought to be like around 1.5 hours. So we know from a perception point of view, it's coming on pretty fast. And so that means that those mood circuits and your association with the world and all those complex things and the huge emotional surges, they're going to be banging on those emotional circuits in the brain very quickly. So we wanted to be imaging around that time. So the participant ingests and then goes in the scanner within like 60 to 90 minutes. And the baseline condition is trying to emulate everything, same time of day, keep everything constant, but they come in for their baseline scan and there's no therapy involved. So we will, in the people that get 2 doses, we will be able to see like a dose escalation. Yeah, so there'll be lots of interesting things to come from that. Yeah, great question. Yeah.
Sir,
Yeah.
then related to that, this was on patients that are treatment resistant.
Yeah.
So
Yeah.
is there, I know you do 2 dosages, but is there plans to do more after?
Oh my gosh, that's the really big question, which is like over to Health Canada, over to people making those decisions, because if there is symptom relief, then Sean Nestor will have to make a difficult decision that this patient is getting better. It's working, and but I didn't have time to go into it, but they actually come off of their meds, so there's a washout period, and they are taking the drug, the active or the placebo, in that therapeutic window. So if it works, then we have new set of challenges, I would say, bigger than this one study. Yeah.
Great talk. I've really enjoyed it. And I just had a question about your triaging system. I know you're not the physician, but patient comes in, they've had a stroke, they get a CT, and if they've got a hemorrhagic bleed, they go this way, right? So,
Yeah.
and then you get to do your work on them. If they've got an occlusive stroke, do they go to MRI for diffusion-perfusion mismatch, or do they go right for TPA?
At Sunnybrook, it's very CT dominated. So in that acute phase, there's some CT perfusion scans that is oftentimes done for hemorrhagic as well as ischemic stroke. And then usually there's an MRI that occurs in days following. So MRI is not being used in that acute
Same
therapy.
here. It drives me crazy, because I mean, to know that if the mismatch is, if there is no mismatch between perfusion and diffusion, TPA is not going to give the patient anything.
Exactly, yeah. So that's where countries are experimenting with more MRI up front. France, for instance, I know they're trying to be more MR focused, some of their centers. So it continues to play out, but it's the call of the radiology and their team, and it's the frontline acute stroke neurologists. They want to just get more TPA, tissue plasminogen activator. They want to get more into the patient, and there's been a big breakthrough in that, because normally you have to do it as an infusion, which drips for some amount of time, but tenecteplase is now going to replace that, and it's just a 1 bolus injection. So that is a big game changer, that it will cut out many minutes, so that would open up more imaging, and ideally there's lots of stuff that can happen there. So, but the one thing is that the worst thing you can do for a hemorrhagic stroke is to give them the clot busting drug. So even though it's a minority, you always need to rule out a bleed. Yeah.
Can I ask one more question?
Yeah.
Do you guys have the synaptive 0.5T up there?
We do actually, and that's the Alzheimer's story that didn't make it into the presentation, but we are planning to scan people with signs of amyloid in their brain. We will scan them at the 0.52.
Because we're testing for the anti-Alzheimer's drugs, right? It's a perfect system for that.
Great. Sounds like we should chat a bit more
We should
because,
chat.
yeah, that's what we're hoping. The biggest news in decades is the use of anti-amyloid drugs, which I think it was it Monday this week or Monday last week was approved in Canada.
Yep, last week.
Last week.
But you need to, when you're doing the patients, you need to actually have an MRI when they're on the drug, when you're like giving them a new dose, because if they start having bleeds, you need to rule that out and stop the treatment, right?
Exactly.
Yeah.
So a patient will receive somewhere between 12 and 24 infusions. Every time it could produce a hemorrhage. It's a very low chance, but they're small microbleeds that are not to be ignored. So, yeah, question?
So I wonder, in your measurements of the thalamus, are you able to subdivide to the different nuclei? And what I'm thinking of, you mentioned some sex differences. So in all mammals, so we'll talk about humans, the primary visual cortex is about 20% larger surface area in males than in females. So I would expect the dorsolateral LGN to also be much larger.
Interesting. Yeah. So regarding your first question, we were excited to think that we could start to look at the subthalamic nuclei. I think it's going to take some more work. The contrast, Mike needs to figure out a sweet way to image the thalamus and get great contrast. Because although those pictures that I showed you would suggest that it's possible, we will be trying that at 7 Tesla, but I think it's going to be very difficult. And there's some papers on that, which I think it's somewhat promising, but still also could be better. So regarding your second question, I think it's a really interesting area to think about the shape of the thalamus, because there could be sex differences in the shape, the front part of it, the back part, and it could relate to what you were suggesting there. So we did not pursue that, but there's nothing to stop us from trying that. So it's a nice suggestion. Great.
Can I add to that?
Yeah.
Look up a couple papers by Terry Peters and his PhD student Sean Dione from about 10 years ago. You may know them.
Actually, we definitely, I'll check that out.
Segmented the thalamus beautifully.
Right, okay.
Yeah.
Okay, good stuff. Canadian talent, yeah. Great, well, I guess we're at time.
So we'll be having the usual cheese. I don't know if we have wine anymore. I guess that starts pretty soon. Out in the lobby, if anyone would like to speak with Brad more about his research. Thanks a lot for coming out to the talk, and thanks, Brad, for giving us a great talk.
Yeah, it was a really great experience.